Good morning, Bruce et al. I guess I'll be talking to you directly, Bruce, and those who will be seeing this later on a video. So, a pleasure to be here. Michael Kim from UW, American Family Children's Hospital. Once again, just kind of briefly, my EMS experience has been for the last probably about 15 years with Milwaukee EMS, doing a lot of pain management advances, and here I am, the Pediatric Medical Director for ALS Consortium in Dane County. So this is really an important issue for all kids alike, and EMS has been the forefront of taking care of these kids. So I really appreciate those of you who are on the front line and willing to take care of the patients. So thank you. With that said, we are going to talk about two topics today. First hour we'll talk about pediatric seizures. And then the second hour, we'll talk about pediatric cardiac arrest. So with that said, let's just jump right in. Bruce, if you have any questions, please do not hesitate to ask away, because this is sort of as much as it's going to be, I don't want to call it a lecture. It's a presentation of topics and issues, and that I feel is important. So please do ask and stop me and do ask questions so we can have a dialogue. I'm sure if you have questions, I'm sure others do as well. So, okay, so we're going to talk about seizures. So pediatric seizures is a very, very common problem. It's a lot more common than you think. As I've done some chart review a couple of months ago for pediatric runs with the Dane County and ALS Consortium, I realized there's a significant number of patients who's having seizures for pediatric patients who are being seen. So I have a little different level of respect for seizures as a chief complaint for pediatric patients being seen in pre-hospital setting. So basically what we'd like to do is talk about seizure. There's a lot of different types of language that are being flown around for seizures, and then address, we'll define the language itself, and then the seizure different types. And then we'll sort of talk about how we can evaluate these kids fully to really not to miss anything significant. And with this evidence intervention, that there's some evidence-based guideline that's available. So we'll look at that a little bit. And then what usually happens in the emergency department. Okay, so, all right, so Bruce, if you have a question, just let me know, okay?
Yeah.
All right, so first of all, so I'd like to, oh, no problem. So I wasn't sure whether that was your voice or not. There you are. Okay, so first of all, I'd like to go over a few of the terminology that's used. So I just like to use this match game. So first is what is the most common seizure type in children? So Bruce, you have any thoughts as to what's the most common seizure type in children? Of the options, febrile seizures, right? Correct. So febrile seizures. So febrile seizures is the most predominant. So I would say probably more than 60 to 70% of the patients who are having seizures who don't have any seizure problem in the past is going to be febrile seizures. So that's pretty benign, and we'll go into it a little bit more. But just know that these are very self-limited, relatively benign episodes that requires workup for fever rather than workup for seizures. So what do you call a seizure that lasts more than 5 minutes? Any thoughts, Bruce? So I mean, there's only one option that applies to there. So that's status epilepticus. So status epilepticus is a fairly serious condition. The duration of seizure has changed over the years. And it used to be half an hour decades ago, but now it's come down to 5 minutes. Somebody who's having seizure more than 5 minutes is considered to have status epilepticus. And this is something we need to work on immediately, because the outcomes and the prognosis gets pretty dismal after a certain period of time. So seizures more than 5 minutes is considered status epilepticus. All right, so what about a period of decreased mental status after seizures? This could be 5 minutes to even a half an hour. So I've seen some kids even up to an hour. So What do you think, Bruce?
No.
Post-ictal period. So this is a very important part of a most seizure. So we usually in the emergency department, when I see patients, I use this period, presence or absence, to really look at, did the patient really have a seizure or not? So if there's a classic post-ictal period, it's likely that patient has suffered a seizure episode. If they don't, you need to start thinking about what other things that could have happened besides seizure, that patient lost consciousness or whatever the complaints are. So post-ictal period, very important part of a full typical seizure episode. What about uncontrolled brain electrical activity? What is that? What is it defining? I guess this would be a Jeopardy question, right? Jeopardy. Here's the answer. What's the question? So what does uncontrolled brain electrical activity define?
A seizure.
Seizure, absolutely. So the reason it's up here is that I want to make sure that I differentiate between the epilepsy, which is a medical condition in a patient that causes recurrent seizures, versus seizure. So a lot of people do have confusion between the two terms. Patients having a seizure, patients epileptic. Epileptic patients will have seizures, but the patients having a seizure may not be epileptic. So these are two complete different terms. So I don't like to use the word epilepsy per se. We usually use patients with history of seizures. So, but that's my preference. So definitely seizure is a subset of patients with epilepsy, that activity that occurs. So two different meanings. Thanks for participating in the match game. I appreciate it. Okay, so this is a little bit dry, but it is important for us to classify different types of seizures. So usually these seizures are categorized into partial, or we call focal, and generalized. So when we say partial or focal, it means it starts in only one part of the brain. So if usually the right side of the brain is where the focal activity starts, usually it's the left side of the body that's going to have the visible, at least the seizure visible clinical effect. So if the right side brain is being affected, the left side of the body usually will have shaking, etc. So if a patient has a seizure that starts in one part of the body and progresses general, that's still considered partial becoming general. Okay, so that in partial seizures, you have a simple partial, meaning my arm is twitching or my lips are twitching on the one side or the other. Then the complex partial is a little bit interesting in that I have my arms twitching, but I lose sensorium. I have a brief blackout, but movement, or at least the motor component, is only one side. So that's what we call complex partial seizures, but that's considered a partial seizure. So now we move to generalized seizures. Generalized seizures means the entire brain is having electrical short circuiting. So these represent a couple of different types of absence seizures, absence seizure, tonic-clonic, myoclonic, and atonic. So absence seizure is the one you have typically these are a few seconds of blank staring. They have no cognition or no understanding of what had happened, but they just look away in the far distance for a couple of seconds, and they pay attention again. So these are usually teachers recognize this because they look at their students and see whether they're paying attention. These students are just staring away, daydreaming for a few seconds, coming back. So these could be a very subtle signs of absence seizure. So if you're very observant, you should be able to pick this out. But there's no typical classic movements associated with this. So absence seizure is a blank staring, sort of loss of sort of cognition for seconds to even, it's usually described as seconds, a very brief period, and you just kind of tune out. So that's what you see in absence. And tonic-clonic obviously is a very shaking. There's a twitching. Tonic-clonic is a generalized, meaning the entire eyes, arms, lower extremities is very violent, depending on how severe it is. So this is describes a meaning tonic-clonic is the entire body. So myoclonic is another one that is very, it's a twitching, some sort of, it's not a violent, but myoclonic is a very subtle muscle movements that are usually seen, but it's usually generalized as well. And then atonic is it's a seizure which you just lose all tone, you just collapse on the floor. But these generalized seizures usually are associated with a complete loss of consciousness. And these will usually, except for absence, will usually manifest with the postictal period. Okay, right into febrile seizures. So as I described, this is the most common presentation of kids with seizures. And fairly common. I mean, I usually like to admit this to all my patients, but you know, he's a victim of a febrile seizure right here. So I was told that I had febrile seizure when I was a baby, and you know, could still, you know, make out okay after having a seizure. Maybe I could have been a rocket scientist, maybe not. But febrile seizures are very, very common. You know, about 2 to 5% of kids, usually kids of less than 5 years of age. And most last about less than 10 minutes. Usually only a couple of minutes are the most common. But it's usually generalized or stiffening, etc. And with the follow-up by postictal period. The temperature, you know, we really don't know exactly what the true cause, etiology of febrile seizure is. So usually we talk about elevated temperature. So greater than 39 has been mentioned as a requirement, but it's the absolute the temperature is just not important. If the patient somehow is related to fever. So the other question is, a lot of people argue that actually having a seizure itself will increase the body temperature. So the question is, how do we study this? Can we cause a seizure to somebody and measure the temperature? We can't. It's just ethically, we can't do that study. So febrile seizures are seizure episodes that are associated with temperature elevation. So, and the thing is, we really don't know what the true cause is. I said, is it infection? Is it metabolic issues? Or is it the absolute temperature, or is it the rise in the temperature, how fast it rises? So we really don't know. So there's a lot of different thoughts on what may be causing it. But at this point, we still don't know what the true cause of febrile seizures are. But it is not a meningitis or sinus infection. It is not a metabolic problem. And it is not related with any history of previous seizure without fever. Okay. But most of the febrile seizure patients are relatively well. However, there are some patients who have complex febrile seizures, meaning having 2 seizures within 24 hours, or has a sort of prolonged seizures. These patients will definitely need an ED workup, meaning really look at what's causing the fever. So most babies who have febrile seizures, they will have either viral infection, ear infection, UTI, or any other type of pneumonia, etc. So if the patient clinically has an issue to be evaluated, I think they absolutely should be transported to the hospital for evaluation. You know, personally, I like to look at these kids for sure. Then they have no other medical issues. So if the patient has any previous medical issues, any complex medical problem, they probably should be transported to be evaluated. If the patient looks well, compliant family, and they have an appointment with the primary physician that day, I think it'd be reasonable to forego transport. But by and large, my preference, because I can only look at it from my perspective, is that these patients will need an evaluation to see what's causing the fever. Because if they have another one, it's gonna count as a complex febrile seizure, and we usually end up getting a lot of tests and other concerning differentials too. So, so I can't say for sure every patient needs to be transported, but there are possibilities that febrile seizure may be due to underlying medical infection, other issues that may need to be worked out. So status epilepticus, we talked about this, the duration, anything over 5 minutes or more than 1 seizure in 5 minutes. So that's the definition of status epilepticus. So this, obviously, patient having multiple seizures within 5 minutes without regaining consciousness is considered an ongoing seizure episode. Thus, it's really difficult to recognize these issues when patient's not conscious. So patient may not be having any seizure activity, but they may not be conscious, but they actually could be having subclinical seizures too. Patients who have history of seizure disorder or epilepsy has a higher risk factor for status epilepticus. So if a patient is continually seizing for more than 5 minutes, it is highly likely or likely that the patient may have underlying seizure disorder. And if the patient does have prolonged seizures, there's a higher chance of having long-term morbidity. I've even taken care of patients that have prevention should be immediate, whatever you can to really stop the seizures. Using medications will be probably the most likely. So febrile seizures and most seizures will stop in a couple of minutes. Those you can observe, but if anything more than 5 minutes, you should do whatever you can to stop those seizures. So what about the kids with history of seizures? So what if you have a history of seizure or what we call epilepsy? What is the usually presentation for these patients? So the causes in these kids are usually most of the time it's medication related, meaning subtherapeutic dosing or they're just not giving it is one possibility. And the other is when patients have a medical, say the viral infection, sometimes they really mess up your liver metabolism. Sometimes the medication gets metabolized quicker. So if you're on antibiotics per se, azithromycin especially, will really enhance the metabolism of your liver. So your medication gets metabolized quicker, so you don't get enough level in your system. So there are many other subtle environmental medications, other issues that could really alter the level of seizure medications. So it's usually medication related. The other thing about these kids are parents are intimately familiar with their kids' seizures. So they can tell you exactly, this is exactly the same seizures he's had all his life versus this is completely different. So in those cases, then your approach should be somewhat different based on their information. And special needs patients, this is a little realm that is beyond what I need to talk about. But special needs patients are at a risk for many different things, not only their underlying medical issues, but they're also at a risk for what we sometimes don't think about, it's a non-accidental trauma. So if the patients are very complicated, they're very emotionally draining to parents, they are at a significant risk for non-accidental trauma. So you need to really have non-accidental trauma as a potential working diagnosis when you're seeing these kids. And any patient with history of seizures or having a seizure, they will invariably need medical evaluation. So I would strongly recommend having those patients transported. Okay, so what are some of the causes of seizure? There are many. One is provoked, and the other is unprovoked. So of the provoked ones, there are many different causes. So infections, it could be as simple as viral infection, or it could be as serious as meningitis or encephalitis. So that's something to be thinking about. If the patient has a fever, it's likely caused by some sort of illness. It could be something mild, upper respiratory infection. But if the patient is obtunded, has a neck stiffness, or has a petechiae purpura all over, suggesting meningococcemia, then you will know the cause. Excuse me. And then we talked about trauma. Any patients who is having seizure after head trauma, car crashes, falls, obviously those are likely. But in young kids who are not moving, non-accidental trauma should be strongly considered, and you need to bring those patients in for a full evaluation and not only to intervene at the time. Although not common, some metabolic conditions can cause seizures. They include hyponatremia, hypoglycemia. So if the patients have any sugar issues and has been dehydrated and not drinking a lot of fluids, etc., so those patients will have ongoing issues. So they may have had a brief seizure, but they will be altered. If the patient comes completely back to baseline within minutes of having a seizure, it is highly unlikely to be metabolic. However, hypoglycemia sometimes with seizure activity will release some sugar. So you may have a slight increase in sugar, but regardless, metabolic is one of the causes that we investigate if the patient is not back to normal. Toxins exposures, so medications and drugs could cause seizures. We've had a handful of kids being exposed to hypoglycemic agents and other teenagers, drugs of abuse, cocaine, etc. Will be of another thing we need to worry about. We talked about fever and vascular causes, sometimes very atypical migraine, ischemic findings, and I think strokes in kids are very, very rare. However, we were just talking about earlier this morning, we've had 4 cases of strokes in Dane County in the last 4 months, and severe, bad cases of stroke. So strokes can happen in patients. And the other oncologic conditions, meaning any brain masses, any other sort of mass effect to the brain could potentially cause seizures too. So pretty broad causes that you need to think about that are provoked that ends up having the seizures. But I think you need to, when you see a patient, you should fall into one of these categories, really think about what it could be. If it's a simple febrile seizure with some URI symptoms, that's a patient you may need to decide to transport or not. But all the others, I would hope that you would be able to transport these patients. And then there are the patients who are just unprovoked, who just has idiopathic or just had a seizure because it was destined. So there's no way for anybody to find that out immediately, but these patients will end up getting a neurologic workup if the symptoms continue, meaning with one brief seizures, we usually don't do any workup if the patient looks fine, clinically well. However, in the emergency department, if the patient comes in for 3rd seizures, or even 2nd or 3rd seizures, then I would really trigger the workup, maybe getting an EEG, or potentially getting an outpatient MRI with a neurology follow-up. These patients will end up getting some more studies and to really look at what's causing these seizures. So unfortunately, about less than 20% are identifiable. So look at all these seizures. So about 4 out of 5 patients, you just don't know what caused it. So a lot of it is just unknown causes, but we do our diligence in making sure we look for the causes. So I think those patients with high risk factors should definitely be transported for evaluation. All right, so what do we see? What do we look for in seizures? So subtle seizures are very difficult to tell. So if it's obvious tonic-clonic seizures, it is clearly evident, very violent, and a lot of people are disturbed by it. But subtle changes in behavior. My child is all of a sudden today for the last hour is not acting normal. It's one thing, that could be that. Or stiffening, increased tone of the body, or loss of the tone, and eye movements, different eye movements and nystagments, and drooling and frothing in the mouth are very typical signs of a patient who are about to have a seizure. And rhythmic twitching or jerking is a tonic-clonic manifestation of seizure. And the other very subtle things would be patients say, you know what, something's tasting funny. And if you ask a lot of patients who you may know have seizures, do you know when you're about to have a seizure? I think most patients will know that they are about to have a seizure. I feel something coming on. So it's sort of an aura. There's the bitter taste, metallic taste. And then patients are, if the movements are somewhat irregular, it's purposeless. And fluttering of the eyelids and sudden falls, teeth clenching, and temporary sort of stopping, apnea, or sort of dysregulation of the respiration. These are very subtle findings of potential seizures. So it could be anything, basically. Okay, so when you're evaluating these patients, I think it was really difficult to when I was organizing to talk, what is the first thing that you do when you come upon a patient with a seizure? So Bruce, I'm going to put you on the spot once again. What is the first thing that you do when you come upon a patient with a seizure?
Do they have previous history of seizures?
Mm-hmm. So I think you get judged. So I think clinically that we get history of what had happened, right?
Yes.
But what I'm trying to get at is there are certain things that you must do when you come find a patient with a seizure, even prior to getting all the history. Tell you what, let me get there, because I would try to draw something out from you, but we're going to get there, and we're going to discuss it a little bit further, okay? So important seizure history.
Breathing, okay.
There you go, perfect. So ABCs, and then airway, breathing, circulation. Then there's something else that comes right after that I'm going to go into that is unique to what I talk about. So that's a sort of maybe that's an added value to this talk. So ABC definitely. We'll do a pediatric assessment triangle, right? Looking at the alert, mental status, breathing issues, and the color. Just a quick glance of 5-10 seconds will give you a good sense of whether the patient is sick or not sick. So when you get into the seizure history per se, so basically you want to learn about, did the patient have any warning signs? Did the patient start puking? Did he have any illness? Did he have any vomiting, etc., over the last day or two or hours? Any head, eye, lips, and tongue movements? Did the seizure start at one area to progress to another? Did it start at one arm, go to the body, or started at the body and went to one arm? Patient conscious or not? How long did it last? And this is one of those questions I know the answer is going to be, I don't know. It seems like days, but actually trying to nail down on the duration would be really helpful, because if it's more than 5 minutes, definitely it constitutes a status epilepticus condition. Apnea. So asking parents, so was he or she breathing at the time of the seizures? So this is another question that really you just don't get a clear answer. I'm not sure. It's very irregular. So if the patient turned blue, cyanotic, then you could guess the patient probably was apneic. And the other question you want is any loss of blood or bowel function. It's another information that'll be really helpful. And then what had happened after the seizure stopped? Did it stop by itself? Was there any bleeding, biting of the tongue? Did the patient wake up and go to the bathroom and come back and want to sleep again? Or did the patient became postictal and was sleepy until you arrived? And when the patient went back to baseline, did the patient wake up 5 minutes later, 10 minutes later to become normal again? Or did the patient immediately after the seizure was over get up and was back to his baseline? So these are the important factors that we utilize. It doesn't tell you one way or another what had happened, but these are important clinical information that we synthesize to really try to make a diagnosis. I think for EMS perspective, I think these information may not give you a clear history of what you need to do, except that if the father tells you, well, you know, my 6-month-old child got up, started walking up the stairs and fell down and hit his head and had seizures, then you would question, how could a 6-month-old walk upstairs? So these are the kind of things you want to get more information to really look at the potential causes that I talked about earlier. Other histories and factors. Other meaning, does the patient have diabetes? Does the patient have any VP shunts, any other neurologic conditions? So if that's the case, that may be likely to be causing the case. And then other medical problems. If the patient is on other medications that could potentially cause metabolic or any toxin effects. Recent symptoms of URI symptoms or diarrhea, vomiting. If there's significant vomiting or diarrhea, you may consider possible metabolic insufficiency, such as hypoglycemia or hyponatremia. And then developmental history. The patient has not been developing well. Is already a year old and is not walking, is not sitting up. Those are the conditions that you may have a genetic or metabolic condition that could be causing the seizures. And then always ask about medications. What is the patient on? Has the patient been possibly exposed to any drugs? Or did the child was at grandparents' house last night and grandparents are tons of medications, came back? And I just need to mention this because I had 3 cases of this last month. Baby who has been exposed to parents who are, I don't know how to put this, but partiers. I had 3 kids who are actually infants who are exposed to marijuana. One from edibles, the other 2 from actually being exposed in the room with the marijuana being smoked. So yeah, so with Illinois going legal, and now we're talking about Wisconsin going legal, I'm going to leave the political stuff out of this talk, but we are beginning to see more exposures to these recreational drugs in our kids. So that's something you need to think about when you see these kids. And then family history too. So if there's any strong family history of seizures, there may be a concern for genetic component to the source. And I think if you get the information, really complete doing some reasonable head-to-toe exam. Obviously, ABCs being the most important, and then you a quick neuro exam, mental status, is the patient awake, alert enough, or vital signs, and head-to-toe to see if there's any bruises, is there any evidence of dehydration, is there evidence of any obvious infection anywhere, neck, stiff neck, etc. And then do a comprehensive neuro exam, the patient following upper, cranial nerve exam or motor sensory, etc. So I think these will be really helpful in trying to determine whether what may have caused it. Not only that, but to really look at, is the patient still seizing or not? So the intervention goal is the patient assessment triangle and ABCs, as you mentioned, Bruce. But that there's this DEFG. Have you heard of this DEFG component after ABCs? Okay, if you haven't, it's great. If you did, have you?
Never forget glucose.
There you go. All right, you're right on. Excellent. So that's the thing. So don't ever forget glucose. That's probably the mnemonic that I've learned about 10 years ago that I will never forget. ABCs is great, but I think when you come upon a seizing patient who has actually been more than 5 minutes, you assess the ABCs, and the first thing you should be doing is getting a glucose. Make sure that that's normal. If it's not, that's something you could fix immediately to have the seizure stop. And then your intervention is to protect the patient. If the patient is actively seizing, you need the patient on a comfortable, soft surface. Make sure there's no injury to the patient. And then turning the patient to the side, there's no concerns for pulmonary aspiration. The patient does vomit. And then your goal is to go ahead and stop the seizure with medications if more than 5 minutes. And then the other thing, like I said, most seizures that you will encounter are very self-limited, and they are going to be fine. So reassuring yourself that the seizure will stop, reassuring the family that this will stop soon. You will probably write 9 out of 10 times. Okay, so when you're not, that's when you start intervening to make sure those are seizures stop.
Can I ask a question?
Sure, Bruce, go ahead.
Stop the seizure. Is that we make sure it lasts over 5 minutes before we stop it?
I think that's a great question, and I think I would let it go for several minutes. So you do the ABCs, making sure you got the airway, oxygenation. So you have to consider, what do you do to stop the seizure, right? So a lot of protocols talk about 2 different things. One is to give glucose, the other is to give glucagon. Okay, so that's I mean, if it's hypoglycemic, so stop the seizure is giving benzodiazepines, either through IV, IM, or PR, or intranasally, or buccal. So these are interventions that could potentially, it's going to take a couple of minutes to work too. So I think it'd be okay to watch these patients for a couple of minutes to make sure they do stop. If they don't, I think you need to still intervene. So in my ED, because we're in the emergency department, I think if anybody seizes, we're there supporting airway, breathing and circulation, oxygenation, and we usually watch. We have the drugs drawn up, and I usually wait several minutes. And if the patient is not stopping, I would say, I would like to say 5 minutes, and 5 minutes seems a very long time. So we do intervene. We have an IV going, so we just push midazolam or Ativan to stop those seizures. So in the pre-hospital arena, because of IV accesses are somewhat difficult, I would say whatever your protocol states to be the first in line, it would be okay to have those drawn up. And I would wait several minutes, at least 3 to 4 minutes before you actually give it. That's a great question. Sorry, I was going down the hyperglycemia pathway because I had that in my head with the DEFG, so that's why I went there. Sorry, apologize. Does that answer your question?
Yes, thank you very much.
Okay. Okay, so we talked about A, B, C, D, F, Gs. So don't ever forget glucose. Perfect. So patient assessment triangle, we went over this, but this is sort of the hallmark, the first thing you do when you actually enter the scene. When you get into somebody's house, when you come upon a scene, that's the first thing you do of a patient. How's the patient look? Is the patient awake and alert looking around? Versus, is the patient breathing normally? Are they having retractions? Are they making any respiratory noises? And then the third is the circulation. Are they pink? Do they have a reasonable perfusion? Without even touching the patient, you should be able to assess this. And this should give you a clue as this patient is sick or not sick, needs an immediate intervention or not. All right, so how do you approach a patient with seizure? So there's a great evidence-based guideline that's been it's been available for the last 6 years or so. That's been established. So this is one of the first evidence-based guideline that's national. Nationally, it's been developed. It's really comprehensive, and I think a lot of the EMS agencies are using this. So it's very complex. It looks complex, but actually it's not. We'll go through some of the elements of this right now. So if the patient's seizing, you do ABCs first, and then you check the glucose. Simple enough. The question is, do we do capillary versus venous blood glucose? You do whatever is the quickest. There are some subtle differences, but if it's low, you have to intervene. So I think finger stick is usually recommended because of the venous access in kids could be challenging. If it's less than 60, so there's a caveat here. So every agency or EMS services have a different cutoff for serum glucose. So 60 is usually the cutoff they've used for infants. But for newborn babies, it's much lower. So 50 or lower, newborn babies is considered pathologic. So if the newborn baby is between 50 and 60, they're okay. If babies that's more than 3 days old, less than 60, then you need to intervene. So you just want to make sure that you know your cutoff and when to intervene. So our guideline in Dane County, the ALS Consortium, we actually just go to glucagon IM if the sugar is low. Because it's simple, easy. Starting an IV is very difficult, especially if somebody's unconscious, unable to take PO. If the patient is not having a seizure and is low in sugar, then you give PO, sugar, glucose. But if the patient's unconscious, then you want to get to actively seizing, you want to go to glucagon or dextrose, if that's in your, whatever your protocol dictates. And if the patient was less than 60 and you fixed it, unless it's a hypoglycemic known diabetic patient who says, oh, I can take care of this. But in babies, if the sugar is low, there's an underlying cause for this. So those patients will invariably need evaluation. In the intervention section, so if the glucose greater than 60, patient is still seizing, then you need to get into other anti-seizure interventions such as midazolam or Ativan or maybe rectal Valium or Valium based on your protocol. And the need for IV is somewhat controversial. If the patient is only 5 minutes away from the hospital and the seizure has stopped after your intervention, I don't think you necessarily have to start an IV. But if the transport time is longer, 20, 30 minutes, I think it would be recommended. It is recommended for an IV to be started if you can. If you do have an IV in place for patients who are actively seizing, Valium or Ativan is recommended. So Valium has a much longer half-life, and Ativan has a longer half-life also. I think those two are the primarily recommended, but in our guideline in Dane County ALS, Versed is probably the quickest. So, in fact, I think Ativan may be off of our list. Do you know, Mitch? Ativan maybe. Yeah, Ativan is out of our formulary. So we're using exclusively Versed. It's a very short-acting, quick medication that could be used through the atomizer as well. You can't use Ativan in an atomizer because it clogs up the spray system. So Versed is used intranasally exclusively as the first agent to use for ALS Consortium in Dane County. And then if And the recommendation from this guideline was that we should allow the EMS providers to really intervene initially without having to call online medical control. So they were really adamant. Calling online control it's a hassle, it delays care. So boom, if you come upon a scene with a patient with seizing, more than 5 minutes, boom, you should be giving interventions without having to bother to call and waste time for online control. So briefly, I'm sure you have as a critical care transport. So atomizer has been really godsend in the last 10 years or so. We use this for Narcan, we use this for midazolam, we use this for fentanyl, we use for many, many different reasons. I think it's just one of those, this is not only effective for the patient without an IV, but it really saves, it's a safety issue for the provider too. So we don't have any needles trying to start an IV, which is very, minimizes a lot of pokes for a lot of providers. And the other is the buccal administration of midazolam is coming. It's a similar mechanism being absorbed through your buccal mucosa rather than your nasal mucosa. So this is something we could do in patient who is actively seizing as well. So a lot of the patients who go from the hospital, go home from hospital from our hospital, usually has intranasal midazolam or buccal midazolam as an agent to potentially stop. So I have not seen buccal midazolam as a part of protocol in anti-EMS protocols, but intranasal, definitely that's something we are absolutely using. For IV access, if patient is, like I stated, it's a longer transport time, patient did have a seizure, definitely something we need to think about. I think those patients would have an attempt or two at an IV placement. And if the patient's actively seizing, if you're unable to control the seizure with intranasal or buccal or rectal diazepam, I think IO definitely should be considered. So the thing about IO versus IV is much quicker to go IO. The time to skin, needle to skin time is 12 seconds versus 25 seconds. And then vascular access time is 17 seconds versus a minute or plus. So that's not accounting for the difficulty in which finding an IV and actually getting it placed in newborn babies. So newborn baby and infant. So much faster. And in patients who are actually coding, I personally would think just do away with the IV and then you go for the IO. But there are new guidelines that came up recently that really says you have a much better outcome if you have early IV access. So I think trying to get an IO and IV at the same time would be probably, but I'll talk about that next hour. All right, so we're going to discuss briefly non-convulsive status epilepticus. This is a very important topic. It is a patient who is actually ongoing having the seizures and is not very visible. So if the patient stops seizing, but patient is sort of in a post-ictal state, but something's not right. So it's a persistent change in the level of consciousness, behavior, autonomic function, and sensorium from baseline associated without major motor signs. So there's no way to know. This could last, greater than 10 minutes, but greater than even 30 minutes on EEG. And you really need to have a very high index of suspicion to really address this. When I get patients in the emergency department who have stopped seizing, and on my examination still, we will consider post-ictal period, but there's something's not right. Patient, there's some tongue twitching, their extremities are still a little bit stiff. The heart rate is really rock solid. The heart rate is at 130 and it's not variable. In those patients, I really do consider maybe potentially for non-convulsive status. So you just got to have a high index of suspicion. And if you are concerned that maybe what's going on, and there may be need for another dose of anticonvulsants. These patients will need continuous EEG to really look at this. That's the only way to know for sure. And if the patient has a prolonged post-ictal period and has altered mental status with subtle tongue twitching, eye twitching, a little wrist fluttering. So if those are present, we need to consider having the patient having non-convulsive status epilepticus. So in those patients with history of seizures, meaning epilepsy, non-convulsive status is more likely than those patients who don't have seizure conditions. It's highly associated with infectious or autoimmune encephalitis, meaning so these patients will have a significant degree of morbidity. And then some other conditions such as temporal sclerosis or structural metabolic causes may be causing this also. So it is very important for us to pick these up and try to stop this. Sometimes medication withdrawal, brain injury, and drug-induced conditions may be contributing to a non-convulsive status. I've listed the things that are absent versus present. So meaning anorexia, meaning not wanting to eat, not wanting to talk, not having any movements. So these are sort of what we will see in patient with any time of seizure or post-ictal period. If the positive of symptoms, agitation, aggression, so you could be having a patient who just had a seizure but is very aggressive. A patient is just blinking, is crying unusually, has some delusions, repeating after you, some twitching, laughing uncontrollably after having a seizure, very unusual, but these are things that you need to think about. But quarter of the patients with non-convulsive status really has no clinical findings whatsoever. So EEG is the best way to diagnose these, but if you see patients that are atypical after having a seizure in their clinical status, you need to think about non-convulsive status. So I'm not sure if any of you have non-convulsive status epilepticus protocol. You should follow your seizure protocol. If a long transport time, I think you may want to consider getting another dose. If it requires online medical control, so be it. Making sure that the patient's airway and breathing circulations are stable for the long transport. All right, so moving on to sort of wrapping this up, helping the parent is very important. So as much as we are upset by the seizures, but there's nothing worse to parents as seeing their child having a seizure. So I have not had to go through this, but I see parents all the time with their kids having seizures. I'm sure you have also. But I think it really helps to really reassure parents that seizures, you're just having a little episode versus, so not mixing up the words. Your patient has, your child has epilepsy. That is not the case if it's a first-time episode. So seizure and epilepsy and intellectual disability, which a lot of parents will conclude to, is not the same. So having a seizure does not mean your child's not gonna be a rocket scientist. So basically what we usually do in the emergency department is really helping them figure out whether the patient's having a seizure or not, and what exactly should be the action if a seizure occurs again. Where to put the child, how to lie the patient on the side versus on the back, what to watch for. And they really reassure them most will stop within a couple of minutes. And you just need to support them while this is happening. And then just providing all the information is really rehashing them so they have good information of what to do and what not to do. So what happens in the ED is that we do, depending on how the patient looks, depending on what our differential diagnosis, a lot of things will happen. We usually sometimes give medications to stop the seizures, do labs, do urine, maybe imaging, CT or MRI, do an EEG, and sometimes we are considered, if concerns for meningitis, we do spinal taps, etc. But basically our biggest priority is making sure the patient's ABCDEF is stable, and then we do a lot of other stuff if required to work up complex conditions that cause seizures. So the take-home points from the seizure in any pre-hospital setting in kids is that most are brief and fairly benign. So you have the time if the seizure begins in front of you, but by the time you usually get to the scene, patient most likely would have stopped seizing. So it is very, very rare for us to see any patient who's actively seizing or have actually the EMS providers actually intervene to stop the seizures. Priorities are patient assessment triangle and doing ABCs and DEFG. Don't ever forget glucose. And if the patient's in status, you need immediate cessation per your guideline or your protocol. And know the recommendations of the protocol. Really owning your what to do intervention is very important. If not, readily have it next to you so you can be referred to it. I would say most patients who have seizures will need an ED evaluation. And I think unless the patient is obviously known as diabetic who just had a little extra insulin or just didn't eat, I think those patients may not. But most patients who have had an active seizure episode, I would recommend getting an evaluation done. And then, looking for etiology or source that is not only your job, but our job as well to figure out what may have caused that seizure.